Bismillahirrahmanirrahim. Let's say the urinary incontinence. Patient cannot stop or urine. So in this condition is known as urinary incontinence. So there are different types of urinary incontinence, and we have to look at their management. So let's see. Come to the urinary system. Urinary incontinence is inability to hold urine, involuntary urinary leakage. For better understanding of urinary incontinence, you have to look at the urinary bladder and urethra. Okay, so here is the urinary bladder and here is the urethra. Okay, so if you look at their anatomy, we have detrusor muscle, we have internal sphincter, we have external sphincter. Okay, so this is the detrusor muscle in the urinary bladder, and here at the neck of the urinary bladder is the internal sphincter. Okay, and this is the external sphincter. So if you look at their innervation, so this internal sphincter is supplied by alpha 1. Okay, so only sympathetic supply, while the external sphincter is a somatic, which is a voluntary muscle, so it is supplied by NM, pudendal nerve. Okay, and if you look at the detrusor muscle beta 3, which means the sympathetic supply, okay, which relax the detrusor muscle, and there is the M3, okay, which is cholinergic supply, or you can say parasympathetic. So detrusor muscle have both supply the sympathetic as well as the parasympathetic. So that's why ANS, autonomic nervous system, M3 and B3 in the detrusor muscle, and internal sphincter has the alpha 1, while the external sphincter has the NM, which is the pudendal nerve or the somatic. Okay, this is the involuntary. Detrusor muscle is involuntary, internal sphincter is involuntary. So what is voluntary is the external sphincter, because it's supplied by the somatic nerve. If you look at the feeling, it's a sympathetic. So and where the detrusor muscle relax by the help of beta 3. Okay, and these both muscle contract. So urine start to fill the urinary bladder, and the storage occur at the low pressure, and there is perfect continence because these are the sphincter are closed. Okay, and if you look at the capacity, so usually 300 to 600 ml urine store in the bladder normally. And if you look at the intravesical pressure, meaning in the bladder, it's a 0 to 20 centimeter of water, and in the urethra it's 100 to 120. Mean the pressure is greater in the urethra, so that's why these sphincter are closed. Okay, so when the intravesical pressure is less than the urethral pressure, so urethra will be closed. Okay, so this is happening in the filling phase. What is happening in the maturation, which is parasympathetic as well as somatic? So what happens? How maturation occur? Maturation occur by the detrusor muscle the contraction as these two sphincter relaxation. Internal sphincter by the help of parasympathetic, while the external by the help of the somatic nerve. Okay, the pudendal nerve. Okay, so for the easier, you know better when there is a fight and flight condition. For example, you are running away from dog. You do not think to urinate. Okay, so that's why during the sympathetic it's a feeling phase. So when the micturition is associated with the parasympathetic phase. Okay, when you are in the normal condition, not in a stress. Okay, and what is happening? So you do the periodic complete voiding, when you urinate completely, and it's low pressure, which is convenient. Okay, what is normal for the frequency of urination? So in the day it should be less than 8, and in the night it should be maximum 1, not more than 1. So if it's more than 1, mean it's the symptom for the urinary incontinence. Okay, first desire to void when the volume reaches 150 to 300 ml, and this is first, and you can stop it by the constriction of the sphincters. Okay, and then the strong desire come when you run to your washroom. Okay, this is when the urine volume reaches the 400 to 600 ml. Okay, but after the urination, what is happening? So the 50 ml is remaining in the urinary bladder, so it's a residual volume. So after the urination, so it should be 50 ml. If it's more than 50 ml, so mean you have not complete voiding. Okay, so this is one of condition of the urinary incontinence. What is CNS role to control your micturition? So pons actually facilitate for the urination, while the cerebral cortex inhibit the urination. Okay, when you want to the urinate, first of all, we have to inhibit the cerebral cortex because it's inhibiting the maturation. So for the to start maturation, so the pons give signal, so we start the urination. So this was the small summary of the anatomy and the physiology of the urinary bladder and the urethra. Let's come to the urinary incontinence. So number one condition is the increased abdominal pressure, for example, due to exercise or due to cough. So it's put pressure over the bladder as well as over the urethra. So if this pelvic floor is normal, so there is no problem, no leakage of urine. So if this pelvic floor is not normal, mean it's a weak, so what will happen? So this the urethra will come out of the pelvic floor, or it's there would be a prolapse. So why? So that's why the pressure in the urethra decrease, and the pressure in the detrusor muscle is going to increase. Okay, increase in intravesical pressure and decrease in intraurethral pressure cause the leakage of urine. So this condition is known as stress urinary incontinence. So this is number one, where the urine leak on the stress like cough and exercise and other any straining work. Okay. And what is a clue point? Clue point is this does not occur at the night. It's not present with the urge. Urge mean he cannot stop the urine. So it's only urine leakage over the stress. Okay, it's not mental stress. It's the exercise stress, or where you put the pressure over the floor. Now, so this is second condition where the detrusor muscle continuously contract, continuously contract. So this is a involuntary contraction. So this is known as the urge. Okay, but is presentation? Presentation is urgency. Mean a patient cannot stop the urine. Okay, so when she have to go, she have to go. Okay, so there is no other option. And in the frequency, mean she is maturating more than eight or more than one in the night. Okay, and some urine leakage. So what is clue point? Clue point is the bladder contract. So this is associated with the urge incontinence. Okay, so other type is the mixed, mean where you see the stress as well as the urge incontinence. Okay, so this is the third. Now let's come to the next type. Here you see the blockage in the urethra. Okay, so this is the next condition. What will happen if there is urethra blockage? Means the patient cannot urinate easily. So what will happen? So the urine start accumulating in the bladder. So there will be the overflow. Okay, so when it reaches maximum, okay, so what will happen? So some urine comes in form of the drops. So it's not due to the contraction, it's due to overflow. Okay, so it's an incomplete wedding, mean the patient does not completely maturate, and there is persistent small urine leakage due to overflow. Okay, what is clue point? Clue point is the increased residual volume. So what is normal? Normal is the less than 50 ml. Okay, so if it's greater, so it's may reach up to 1000. So it's a condition of overflow. Okay, so this is the fourth one. And the next type is the if you see the foreign body in the urinary bladder, this is what infection in the urinary bladder, tumor in the urinary bladder, or the stone. So this all cause what? Irritation. So due to this irritation, so there is irritative urinary incontinence. Irritative urinary incontinence due to the foreign body or infection, stone, tumor, enemas in the bladder. So that lead to what? The irritation. So that is the irritative type of urinary incontinence. Okay, what is the presentation? Presentation is the urgency, frequency, mean and there is dysuria, mean painful urination. So okay, difficult to urinate, but there is also some urine leakage. Although it's a dysuria, mean difficult to urinate, but there is some urine leakage due to this irritative. Okay, and what is the clue point? Is the nocturia, mean urinate in the night time. Okay, so there is urination more than one in the night time. So this is the irritative. Okay. So next is the fistula or the diverticulum, which is total incontinence or the bypass incontinence. Okay. So because the urine is continuously coming out of the fistula or the diverticulum, it's not coming from the urethra. So it's coming from the fistula, which like in the vesicovaginal, mean there is the connection between the vagina and in the bladder at this point. So this lead to what? Continuously urine leakage. So this is known as total urinary incontinence. Okay. So urinary leakage through fistula. So there is urgency and there is frequency, and post vital urine leakage mean the patient come from the washroom and but she urinate. Okay. So what is the equipment? There is a continuous leakage. Continuous leakage denote the total of the bypass urinary incontinence. Okay. So here is the mnemonic for the causes of urinary incontinence. So diapers, which represent delirium infection. So and atrophic vaginitis, he represents the pharmaceutical, psychological disorder, endocrine disorder, restricted mobility, stool implication. So these are different causes for the urinary incontinence. So these are the types of urinary incontinence. You know whether this is a stress, during increased abdominal pressure, urgency, where you see the continuously contraction, overflow, means you can see there is overflow of the urine volume. Okay. So that lead to leakage, or sometimes due to neurogenic incontinence, where the nervous system is not working normally. So like in the stroke or in the diabetes mellitus, so any abnormal disorder, so that cause the leakage. Okay. So how we start with the urinary incontinence patient? So we take the history for the associated symptom like urgency, frequency, dysuria, urgent incontinence, wedding difficulties, poor stream, straining, incomplete, empty. So these are symptoms are associated with the urinary incontinence. Okay, and you will ask about there would be a prolapse or take the obstetric, mean if she is multipara, so and the risk of the prolapse. Okay, and you have to take the history of recurrent UTI, urinary tract infection, or episode of the retention, fecal incontinence symptoms, and take the history of diabetes, drugs, diuretics, alpha blockers. So they, because they can cause the micturition. Okay, and neurological symptom like paraplegia, hemiplegia, which lead to what? So there is no innervation toward the bladder, so which lead to the urination. Okay. So and you have to give the urinary diary, where she have to fill about the routine of their urination and the other data. For example, what kind of she eat, drink, like coffee, 2 cups, and the urination how many times, 12, and amount was small, medium, large, and accidental leak, yes or no, large, small, medium, and how do you feel a strong urge to go, yes or no. So these are this is the diary she have to fill. Then you can go for the diagnosis. Okay, and paired test to check the amount of urine leak, and the MSU, mean the midstream specimen urine analysis to see the is there infective agent are present or not. So if there are microbes, so mean it's there is chance of infection. So urinary, the culture and sensitivity to check out the UTI, and the frequency volume chart where you see the maturation for the last 24 hours, and look for the ultrasound to look the normal pictures of the bladder, and the other fistula or any abnormalities. So this is a daily bladder diary. Thank you very much. Allah Hafiz.